It's loading, sorry. All right, with that, Emily, you may begin whenever you're ready.
All right, can everyone see this okay?
Yep, we can see it.
Great, wonderful. All right, so my name is Emily, and I'm going to be talking about the psychological effects of childhood cancer. So I'm going to give you a little bit about who I am, because why should you listen to me whenever I haven't proven that I'm knowledgeable on the subject? So sorry if you can hear some background noise. My cat is playing in the background. So my name is Emily Burnside, and I'm an 11th grade student in Texas. And I currently have clinical experience in the real world of healthcare with a CNA license. Actually, I'm still in my scrubs. I just got home from my rotations. So I am continuing my education in medicine next year when I obtain my phlebotomy, EKG, and PCT licenses. And the main reason why I'm telling you this is so that you know that I'm interested and involved in the healthcare field. And I also have an interest in pediatric oncology as my future career, so I do have somewhat of a stake in the subject. So as for research experience, I have previously presented on a topic in the past with Club Med, which was type 1 diabetes. I was extremely knowledgeable on said subject because I myself have type 1 diabetes, though all of my knowledge about pediatric cancer and mental health has been obtained through medical articles, academic papers, and other databases that will be addressed in my works cited. If you would like me to send that to you, I can. So I'm also in the AP capstone program, so I do have a solid foundation in research as well. So with all of that, I hope that you can see me as a trustworthy source, and let's get started. So here's just a brief table of contents to kind of give an idea of the structure of my presentation and how we're going to go about the subject. So first, I'm going to start off with a cancer overview. Then we're going to move into some statistics, psychological effects, and interventions. And I'm going to ask that you please keep all of your questions and comments until the end of the presentation. And I'm going to allow ample time for any questions you may have, but if you type it in the chat beforehand, I might not be able to see it. So now we're going to give a little brief overview of cancer. So I assume that many of you have heard of the cell cycle, so we're going to only briefly touch on the process. So the cell only divides when it needs to. So how do we keep this division in check? Checkpoints. One of these checkpoints is the G1 checkpoint, which determines if the cell should replicate itself. From here, the cells enter S phase or G0, which is just normal cell life. So the cell cycle uses both internal and external control. So within internal control, there are a few different resources utilized for the regulation of the cell cycle. The concentration of protein molecules helps pass along the entire process of cellular replication, so that's how proteins are used. And then the mitosis promoting factor, or MPF, helps the cell cycle progress. And MPF also uses CDK to turn on cellular respiration. So alongside internal control, we also have external control. External control relies on signals from the environment alongside other cells to tell individual cells if they need to replicate. So a great example of this is PDGF, or platelet-derived growth factor. This is put out by the platelets, which are just red blood cells, and then that triggers the fibroblasts to be like, oh my gosh, I need to work, and then they start spitting out more cells, and that repairs the damaged blood vessel walls. So the external stimuli is the damaged blood vessel walls, so then PDGF sends out the platelets send out PDGF to the fibroblast, and then they make more cells. So one way in particular that external stimuli leads to the body to control cell division is through this really cool concept called positional inhibition. And this may only be me, but I totally thought that the cells kind of just hung out in the body and they floated wherever and just popped out other cells when they wanted to, and this is not the case. So positional inhibition pauses cell division because cells have to be anchored to something to reproduce. So it does make sense with the name positional inhibition, but it's kind of hard to conceptualize in picture form. So this is a pretty good illustration of what this looks like inside the body. So this picture on the left is an example of how positional inhibition works in a normal body without cancer. You can see that the cells are anchored to the container and replicate until there isn't any space left. And then they're taken out, and then they repeat the process, and it's a nice, clean, flat sheet of cells. And then the image on the right is what it looks like when cancer just throws all the rules out of the window and does not follow the external stimuli like positional inhibition. So these cells just keep dividing and spreading, and they kind of wreak havoc on the body. So now that we all have a general grasp of external and internal controls, we can put all of this together to determine the checks and balances, so to speak, of our body and cell division. So these checks and balances obviously aren't infallible, and they can let mutations slip through. So mutations can be a result of mistakes within the cell cycle or external stimuli. So there are two mutations that are associated with cancer on a broad scale: the mutation of proto-oncogenes and TSGs. So proto-oncogenes stimulate cell division, and RTK is a protein that helps cells interact with their neighbors. These kind of work hand in hand. So when proto-oncogenes are mutated, the RTK is always on. So these cells are always interacting with their neighbors. And after mutation, it's just called an oncogene. So you only need one copy of this gene to be mutated for there to be a problem. You do have two sets because you get two sets from your parents. And it is also important to note that not all proto-oncogenes stimulate cell division, though for the purpose of the subject, we're kind of just going to be referring to proto-oncogenes as a whole. So TSGs, or tumor suppressor genes, produce proteins that inhibit the synthesis of proteins, that inhibit the synthesis of proteins that cause the cell cycle to occur. So when these genes are mutated, they're always off. You can kind of see where the problem comes in. One mutation's always on, one mutation's always off. So both of these genes work together to regulate the cell cycle, and luckily, when one is mutated and the other isn't, cancer is not always imminent, though this could lead to a predisposition to cancer. So a really easy way to remember the mutations is by thinking about cell division as driving a car. Your gas pedal is your proto-oncogene and your brake is the TSG. When the car works normally, which is just normal cell division, you can put on the gas and brake as needed. Though in mutated cells, the gas pedal is always on and the brake is always off. You can't hit the brake and your cells are just rapid fire hitting the gas and making more cells when it is not needed. This leads to the cancer cell just throwing out all the rules, again, of cell division and doing whatever it wants without regulation. A great visual example of this is positional inhibition, which we talked about earlier. So this is a very simple diagram to put all of those words I just said into a process. So a good part of understanding biology and related subjects is to understand the process in which things happen. So we see this normal cell at the top, which and then next to it is the enlarged DNA. And then these cancer-causing agents, whatever they may be, then take the proto-oncogene and they beat it up. And so now it's mutated and becomes an oncogene, which then leads to the cell becoming cancerous. Obviously, this is a much more complex process than just this diagram, but this is a very good visual explanation. And so now I'm sure you've heard about the different stages of cancer, so I'm just going to give a little brief overview of each one. So stage 1 is where the tumor grows from a single cell. Stage 2 is where cancer cells invade neighboring tissue. And stage 3 is metastasis. I'm sure you've heard someone say, oh, the cancer has metastasized, which just means that the cancer has traveled to other parts of the body. And then stage 4 is almost always fatal, and that's where there are multiple locations of cancer. So now with all of that out of the way, we're going to be focusing on some statistics that relate to childhood cancer to get a really good scope of the problem. So cancer is the second leading cause of death in children 1 to 14, just behind accidents. And so the prognosis of cancer, it can vary quite a bit from 1% survival rate to 90%, and it all just depends on the tumor type. And yearly, it is estimated that 300,000 kids globally are going to be diagnosed with cancer. And in the United States, cancer rates have climbed in the past few decades. As for survivors of childhood cancer, 60% of them will have life-threatening complications in adulthood, and 75% will develop PTSD. And going off that information about the survivors, 2 out of 3 survivors will also develop chronic conditions due to the treatments used: chemotherapy, radiation, etc. So now we're going to be getting into the psychological effects of childhood cancer on survivors. So on the outside, childhood cancer obviously affects the child who had the cancer, but it also affects the family as well. This is a picture of Ashton. She was diagnosed with the type of brain cancer in 2018 and is now completely done with treatment. She's a cheerleader and her care team said she lights up the room. I wanted to include this just to kind of remind everyone, like, there are real people that are going under these treatments that we're talking about today. So many reasons why cancer has such lasting effects on the child, even after it is gone, is due to many factors, including stress from diagnosis. So cancer is often associated with death, so the diagnosis itself is a pretty scary thing. And any type of perceived life threat can induce immense amounts of stress and can lead to PTSD or related symptoms. And so I previously mentioned that 75% of childhood cancer survivors will suffer from some sort of manifestation of PTSD. And the stress at the time of diagnosis and other clinical related events, may this be treatment intensity, length of stay, etc., can contribute to the severity of the PTSD. So another factor that goes into this effects on the child is the physical symptoms. These physical symptoms can have social and emotional consequences for the child as well. Even after treatment is finished, these physical symptoms can affect the child's ability to adjust back to their day-to-day lives because they're set apart from others by their physical appearance. So these symptoms can include treatment-related pain, hair loss, weight changes, physical disfigurement, repeated absences from school and peers. In addition to all of this, these side effects from cancer treatment are more prominent in children because treatment is often more intensive due to the fact that the disease is usually progressing at a more rapid rate than adults, and because children's bodies can relatively tolerate more treatment than adults can. So alongside the physical side effects, children with cancer and survivors of childhood cancer are more at risk for severe anxiety, inhibited and withdrawn behavior, behavior problems, intense stress, PTSD as we've said, academic trouble and frustration, and peer relationship difficulties. One interesting piece of information that I found is that people who underwent treatment or had cancer in their central nervous system had more prevalent mental health problems in future years. So this is most often people with brain tumors or those who received high-dose IV chemotherapies, for example, methotrexate. So both chemotherapy and radiation are common treatments used to treat cancer, though they can have negative effects on the developing brain of a child. These deficits can be presented in multiple ways, though they are most often seen in problems with memory, attention, and language. These treatment-related complications are also contributing factors in the diagnosis of depression and anxiety in childhood cancer survivors. So here on the left is a little boy named Elliot. He's 3 years old and is being treated for leukemia at St. Jude Children's Hospital. His parents say that he just loves life and loves to talk to people, and he wants everyone to talk to him as well. So, we've looked at the effects, we've looked at some examples, but why do childhood cancer survivors experience heightened rates of mental health problems in the future? To deduce this, let's look at trauma on a broad scale. Here are some things to take note of. Childhood trauma is considerably common, and certain regions of the brain are more susceptible to childhood trauma. For example, the hippocampus, the amygdala, and the prefrontal cortex. All of these areas in the brain are sensitive to stress and trauma, but also still in development. So in turn, stress and trauma can permanently affect the development of these areas in the brain. Inhibited development of these vital areas of the brain can lead to risk factors for mental health problems, heart disease, depression, and suicidality. All of these internal factors caused by the trauma of cancer, added with the difficulty that comes with readjustment back into normal life after treatment, creates a violent storm of negative emotions and pressure from peers that lead to worsening mental health in those who survive childhood cancer. And then there are also some social effects that happen in children who have survived cancer. So children who undergo cancer treatment are deprived of leadership skills, which will further stunt emotional and social growth. This doesn't even have to be like a facilitated area of leadership. In many casual situations, children learn leadership and communication skills by watching their peers and contributing ideas to a discussion. So while the child has considerable negative mental health effects after diagnosis, the family is also affected. Cancer takes precedence in the household of those who are diagnosed. So all family members can experience stress related to their child's diagnosis, and this distress can be manifested as anxiety, depression, and symptoms of PTSD. Alongside parents that experience stress, siblings also report feeling anxious, stressed, overwhelmed, neglected, and guilty. This is kind of inevitable. The other siblings of the child who has cancer may be neglected because, again, cancer does take precedence in the household of those who are diagnosed. So then kids in turn will feel guilty for feeling some sort of unconscious resentment towards their siblings with cancer because they feel neglected. And it's kind of just a never-ending cycle. So now that I've kind of just spewed all of this somewhat depressing information at you, what do we do about it? So obviously these problems aren't totally avoidable because chemotherapy itself is trauma, and as we've seen, it can affect the development of certain areas of the brain. But we can be proactive towards giving more mental health support towards children with cancer during their diagnosis and treatment so the survivors are not left to pick up the pieces in adulthood. So biggest one is support. Not only from the family, but from the classmates, the school, and the hospital. This can provide better adjustment to treatment and out of treatment. And again, family-focused therapy and dedicated time to discuss feelings, worries, and stresses on a family level will help all members of the family unit regulate their emotions about the diagnosis. And bringing awareness to psychological stress that comes with cancer will help bring more resources to creating more spaces where cancer survivors are able to focus not only on their physical health, but their mental health as well. And again, survivors are often left in the dust after treatment with no resources for their mental health, so giving resources to survivors is incredibly important in the inhibition of severe mental illness. So behavioral interventions like therapy can help in multiple ways, including dealing with emotions and adjusting to illness and life changes, coping with treatments, physical symptoms of cancer, following medical plans, reducing stress during procedures, identifying and treating depression and anxiety, assisting with end-of-treatment transitions, be this end-of-life care or leaving treatment altogether, supporting families and relationships, and helping families cope with grief and loss, and supporting survivors. So with that, that is the end of my presentation. This is my contact information if you had any questions you don't think of now. And if you'd like my works cited, I can send it to you if you email me there. Without further ado, if you guys have questions, I am happy to go ahead and answer them to the best of my ability. And you can type them in the chat or unmute. So I became a CNA through a dual credit program at my school. It goes with a local community college, but there are online courses, and you only need to find a testing center. You can do the entire thing online, but you do need to have some lab hours, but the testing center will help you figure out that logistically. But if you have a local community college near you, a lot of them do have CNA programs. And you can be any age to be hired. I know at least in the state of Texas, you have to be 18 to be hired at a nursing home. You can volunteer at a nursing home, but you cannot work there for money. But I think there's no age limit. And someone asked, how long did it take me to become a CNA? It took me about, I'd say, from August to December. I think that's a little less than 6 months. Yeah, a little less than 6 months. And that's the entire time that I did it. I did online classes, and then I had lab time, and then I just took an in-person test, and I got my certification. Do cancer survivors present less productivity in school due to PTSD? And how can support be known? And how can support be support known survivors? Okay, so yes, cancer survivors. Okay, yes, that makes sense. So cancer survivors do present less with less productivity. That may not be due to PTSD, because there's also other things that other mental disorders people with cancer are more likely to have. I know one of these is ADHD. I didn't include it in the presentation because there's a whole other spiel of things that I could go off on there. But yes, because they are also inhibited in their social skills. So a lot of the time in at least in-person school and back in normal life, you have a lot of interaction with your peers and interaction with your teachers, a lot of presentations, and we don't really realize how often that is presented in our lives. So these kids are deprived of those opportunities to kind of develop those skills. So they are kind of left behind developmentally with their social skills, which in turn immediately impacts their academics as well. In support, I did not ask that. I didn't answer that question. So we can support survivors by kind of just giving them a space to talk about cancer and not kind of shutting them down with like, oh my God, that's so depressing, I'm so sorry, kind of letting them feel their emotions and helping bring awareness to mental health. Bringing awareness to mental health, not only as a whole, but in cancer survivors is so important to being able to fully get the resources that survivors need. Depression in teens with cancer are more common than younger children with cancer. So depression, the statistics that I found, the depression was found after adolescence. So after survivors had passed the threshold of adolescence, sorry, my dogs are barking. After adolescence, they passed the threshold of adolescence, they were counted in that statistic. But I did not find that in my research. So that's definitely a really good question though. Thank you. Thank you. Any other questions? Happy to answer them to the best of my ability. Thank you. Thank you. Thank you. I'm glad you liked the presentation. So a day in my life, someone asked me what a day in my life looks like. Would that be like as a CNA or like a student or in general? In general. So I guess a day in the life in general goes, I go to school online, and then I go for 2 periods, and then I go to my clinical rotations, and then I come home and I do homework. That's pretty simple. So how can we have conversations with survivors without sort of infantilizing them? Is there a specific language that's harmful? So a lot of the time, and it's no one's real fault, you don't even really realize it, you a lot of the time come across as kind of just very sorry, like, oh my gosh, I'm so sorry that happened to you, I'm sorry, but that doesn't really do anything for the survivor. because it's their life, they're living through it, they've gotten through it. But mental health problems, it's in their brain chemistry, it's the chemotherapy, all of those things are relating to their mental health, and there's nothing they can really do to like reverse the past. So saying you're sorry and apologizing and kind of just leaving the conversation surface level is doing a disservice to both the cancer survivor and you trying to help them. So try to avoid kind of just like surface level and let them get into their diagnosis without you, like they should not have to cater to your emotions. It is a very depressing subject. I do not discount that. But if they want to have a space to discuss all of the stuff that they go through and all of the emotions that they're feeling and all of the negative effects of these treatments on them, give them that space. Obviously, if you are not mentally stable to do that, and that's completely okay, you need to put those boundaries in place. But without putting those boundaries in place, you're kind of just leaving a big empty space in between the survivor and you. And you kind of want to get to a point where you can show that you understand what they're going through, but you aren't just kind of leaving it like at, oh, I'm sorry, and then leaving the conversation, if that makes sense. I was thinking about going into pediatric oncology too, but everyone tells me that it's very hard on the nurses treating children. Yes, that is what everyone tells me as well. But you know, it's all about the passion for it. I love pediatrics, and I think that's something that I'm very passionate in. And I'm very passionate for the kids, but I'm more passionate for the adults that are dealing with their children, the parents that are dealing with their children going through this sickness, because it's very hard on them. You know, getting that diagnosis that your children may die, that's very, very hard. And so they're going through like the worst days of their life. So I want to be there to comfort them and let them know that I'm taking care of their child. And also oncology, cancer is just so interesting to me on a broad spectrum, not on like a personal level, but like a cancer, the way it just mutates is very interesting to me. But I think that it does take a certain type of person to emotionally detach yourself from that in any pediatric work in healthcare. Does the chemotherapy itself actually chemically alter their brain, or are increased mental illnesses more related to the situation? Both. Chemotherapy itself does chemically alter their brain in development. So adults are going to be less prone to it altering their brain permanently because for the most part, their brain is fully developed. But in children, those parts of the brain like the hippocampus, the amygdala, and the prefrontal cortex, those are still developing, and they're still very, very impacted by any type of trauma. And obviously the situation of cancer is traumatic, and chemotherapy is traumatic to the brain because it's kind of like toxic. Granted, it's very necessary, but it's toxic, and it will physically and chemically alter the brain, which will impede the survivor and the child with cancer from developing those important skills that are kind of the foundation for higher level thinking. Seeing them in pain, how to manage it. So obviously seeing anyone in pain is really hard, especially whenever you don't have any materials to fix it. But the thing that you can do best is to sympathize with them and empathize with them. Kind of just understand what they're going through. Obviously, go get anything that you could get to physically help them, but be there for them to cry, for them to have a shoulder to cry on, for them to just talk it out and complain it. You don't have to fix everything, especially for cancer survivors. They understand that. They just want someone to talk to without that person kind of just trying to just brush it off as like, oh my God, I'm so sorry, but not letting it get too deep. Let them have those tough conversations with you if they are willing, because kind of having those moments helps them kind of realize that they're not alone in their diagnosis. They're not alone in their continual screening. Cancer is a lifelong thing. Even if someone is cured or treated, if their cancer is gone, they still have to go back in for screenings. They live from screening to screening because, you know, you never know when the next screening is going to give you cancer. You never know when the next screening is going to say, oh, your cancer's come back. So you have to empathize with them on that and understand that their life is different even after their treatment is finished. So the most common cancers, I did research this, and I can look this up right now because it's on my little research paper because I have the answer. So the most common cancers in that are dealing with the mental health effects are ones that are in the central nervous system, so brain tumors, and any treatment that deals with the central nervous system as well. That will, I don't know really why, but I know that it is much bigger impact on the mental health dealing with the CNS. Such really good questions, guys. Thank you. Yes, radiation also does chemically impact the brain, not as much so as chemotherapy, because chemotherapy is like physical trauma to the brain, but radiation, I'm sure you've heard like radiation, you have to wear like a lead vest, you know, it's bad for your reproductive health, but it's a little bit less than chemotherapy, because chemotherapy is just going straight into the bloodstream. But radiation does affect, aside from the trauma that comes from going to treatment, it will chemically alter, it also depends on where you're getting it, but it will chemically alter your brain if it's in development. I feel like more younger children, it's going to impact more so than teens, because teens are kind of ending that curve of development. But younger children, their brain's still like rapid firing, making new stuff. It's continuing to develop. And yes, the little attendance form was put in the chat. So make sure you fill that out, because you can get your service hour on that. And I am happy to answer any other questions that you have. And someone asked, how long did you spend on research for this topic? So I spent about 8 hours total. I did time myself. I spent about 8 hours total. It like was a little bit over, but I just blanket about 8 hours. And I didn't know much about the topic either, so that is what contributed to the lengthy amount of time that I spent. And someone said, what made you want to become a CNA? So this is it's a program at my school. So you have to apply and get in. And I wanted to, it's kind of like a pathway at our school. There are pathways for different careers as well, like law, culinary, all of those things. And so to get onto the final level of the pathway, I had to get through the CNA portion. And then next year, whenever I get my PCT, phlebotomy, EKG licenses, that's like the final level. So that is really the reason why, just because it was offered to me. Can you tell us a little bit about what it's like to do a presentation with Club Med? Yes. So my second one, I've mentioned that before. I really like it. It's a great way to kind of just research a topic that you're interested in. I always love, I'm a very curious person, and I love to not do my homework and research something else, but having a outlet to say these like things that I'm interested in and things that I've spent time learning about is just a great experience for me. And I love being able to attend other ones as well. And it's not hard. You can kind of just do a presentation over whatever you want, whatever interests you relating to medicine. And their guidelines are on their website or their link tree. It's in the link in their Instagram bio as well. But they're amazing. Like being able to just have an outlet to say all of the things that I'm interested in is a great. Yes, Club Med workshops are always better than homework. Yes, that's the website in the chat. Yes, I love Club Med. I love Club Med. I will never stop doing presentations with them. I love it so much. If you have any more questions, just let me know. If not, do your attendance form to get your service hour. So what has sparked my interest in childhood cancer? So pediatrics, I want to be in pediatrics because I want to help the parents. Obviously, pediatrics deals with kids, so I want to help kids as well. But more so, I want to be able to kind of be there for the parent and be there as a fresh face, a person that is dedicated to working with kids. And I also just really love kids' demeanor. They're fighters. They're really willing to bounce back. and they are physically able to bounce back. So I really want to be in that environment, especially since I was in the hospital in and out a lot in my childhood. So I really like the environment of pediatric hospitals. They're so much more upbeat and happy than regular hospitals. And then oncology, cancer, I'm just really interested in the way that cancer mutates and the way that it just doesn't go towards the body's rules, like how it just like does not care. And that's really interesting to me. And obviously, kids with cancer, they deserve a lot of love, a lot of support. But cancer itself is very, very interesting to me. And yeah, if you've done your attendance form and don't have any other questions, you're good to go. Thank you guys so much for coming to my presentation. I had a really good time presenting. And if you don't have any questions, you can just go. What other specialties have you considered in the past other than pediatric oncology? I really was interested in cardiology at first. I thought the heart was very interesting, but then I was like, eh. And then I'm kind of on and off between like wanting to be an ER doctor and also like a pediatric ER doctor or an oncologist. But I feel like pediatric oncology I've stuck with for a really long time. Like I've always come back to it after like, oh, I'm interested in this, I'm interested in this. Thank you for everyone and their nice comments in the chat. Thank you so much. This will be up on YouTube Live if you ever want to re-reference, if you ever need any information about the psychological effects of pediatric cancer, it is on YouTube Live. Thank you guys for attending. If you've done the attendance form, you're good to go. Thank you. Thank you guys so much for coming. Have a good day. Bye. Thank you guys. Have a good day. All right, thank you guys for coming. If there are any other questions, I think